these questions to come. Later on, somebody will ask me what do you mean by spinal mobilization, spinal manipulation. What is the effect of spinal manipulation or mobilization? Before we ask me the question, just I will let you first. So, spinal manipulation is a form of manual therapy used clinically to treat patients with spinal pain and movement dysfunction. A manual procedure that involves a directed thrust to move a joint past the physiological range of motion without exceeding the anatomical limit. As we know, all of you guys, that we have physiological movement, normal physiological movement limit. If you ask me to do rotation, you can go further rotation like that, it's activity. But I can push my hand further. This is the anatomical limit. It means that the thrust or the manipulation will come between two of these limits. It means that we will got the physiological limitation, which is usually come with the active, and we have the anatomical limit, which is usually done by our hands. Again, if I ask you to go for rotation, the left side, this is the limit that you can go further. But still I can push your head further. This is the anatomical limit. And the manipulation will come between two of these limits. If you exceed the anatomical limit, maybe you will hurt the patient. So, this is just a brief about what we mean by manipulation. Okay. The scientific definition for the manipulation, it's low amplitude, high velocity thrust manipulation. We mean that the manipulation is not about the force, it's about the speed. Very fast speed, but low force. Don't just mix between two these things. Some people, they say, if I do manipulation, you need to be a man, I need to be a stroker. You don't need to go to the gym if you want to be a manipulative physiotherapist. Just you need the direction of the movement to be done correctly, and you need high velocity, low amplitude thrust. Clinical skill applying high velocity thrust spinal manipulation lies in the practitioner's ability to control the direction, the duration, and the magnitude of the load. The direction in which the load is applied and the contact point at which load is applied. I mean, if you want to do manipulation or mobilization for C3, C4, you should know where to put your hand. Is it in C3? Is it in C4? What is it exactly in the vertebra itself? That's why we're going through anatomy and biomechanics to understand all this stuff. Okay, here's some rule for the manual therapy or for the manipulation. It seeks either to retain the vertebra to its normal position or to restore the lost mobility. It means that what is the purpose of doing this manipulation? The purpose is that to normalize the position of the vertebra or to restore the lost mobility because of the limitation, whatever the cause was. The manipulation is commonly done in the opposite direction of the movement that caused pain. It means that the pain in the right side, I should do mobilization or manipulation toward the left side. Still, we've got some technique toward the same side. We call it down slope technique, but usually we are not using it unless the patient has like pain 2 out of 10, just feeling discomfort, maybe we can do it. But if the pain is still there, we should do the manipulation away from the side of pain. The pain in the right side, we should do the manipulation to the left side. Okay, spinal manipulation suggests that at least 3 anatomical effects should be sought. The facet joint should be separate. That's what we expect when we do manipulation. There will be separation for the facet joint for this articulation to the side of the pain. And there will be paraspinal muscle should be stretched when you do manipulation toward the left side. This joint will cavitate, will open. The muscle here will get stretched, and also intradiscal pressure inside the disc will diminish. All this stuff that we can expect when you do manipulation. Okay, what is the mechanical effect what is the mechanism of the spinal manipulation? What is the effect? What will happen? There is mechanical effect, we call it increase the range of motion, stretching the capsular and ligamentous adhesion and scar tissue. And also there will be a reflex inhibition of the muscle spindle, which is increase the tone. It means that sometimes also when you do manipulation, we try to activate some muscles, which usually the deep muscle that it's a motor control muscle, like multifidus, like what we call it, deep neck flexor muscle. This muscle should fire before you do the movement. It means that if I would like to do rotation to the left side, this muscle should fire first to support and make the normal alignment for the joint before I go for rotation to either side. Also, for unlocking the intrameniscoid, as I told you, the meniscoid, the meniscus or the meniscoid, usually we call it meniscoid, this will be in the articulation of the facet joint. And when you do that, you will just, unlock to open that area. Allowing joint play also means that you can move the joint in each direction without any pain. And also reduction in the intra-articular pressure. Usually that's with the pop sound that we are feeling all the time in our fingers, in our neck, in our back. These gases will be released and make the articulation, the intra-articular space wider, which will give a chance for the joint to move freer more. Also enhancement the joint nutrition and also the hydrodynamics. Okay, then this is just the same thing what we've said before. Also there is a neurophysiological effect for spinal manipulation or for manipulation. It's a muscle spindle and joint tendon origin afferent are stimulated by spinal manipulation. To do spinal manipulation, you will enhance the mechanoreceptor, which usually the muscle spindle and the tendon itself. Sustained evidence demonstrated that spinal manipulation also evoke the paraspinal muscle reflex and alter the motor neuron excitability. There is some research that has been done after the thoracic manipulation, after the lumbar manipulation, especially the lumbar manipulation. They gone by the ultrasound to check out, and the ultrasound itself, they want to see the activation of the transverse abdominis which is supporting the spine. And they measured the power of that muscle. When they've done the manipulation, when they test the muscle, they found the activity of this muscle was better than before. It means that one of the idea of the manipulation also to enhance the weak muscle to start to work. Also, the phenomenon of the central facilitation is known to increase the receptive field of the central neuron, enabling the either subthreshold and exostimuli across the central spine pathway. And also we can talk about this one. It means that if there is a problem with the spine, if there is a huge pain, and we can activate the what we call A-alpha, which is usually enhance and break down in the way of the C fiber. That's what we call it pain gate theory. Oh, okay, here we go. Also, according to the gate control theory, there were a mechanoreceptor afferent carried by a large diameter axon inhibit the susceptible afferent at the dorsal horn. It means that the alpha, when you do the manipulation, it will activate the A-alpha, which usually will inhibit the C fiber, which usually, deliver the susceptible pain usually in our body. So if you do a manipulation, it will be like, like an analgesic effect. That's what we mean by all the system. Okay. But before the manipulation or the mobilization, to start to think about it, today I've seen my patient. I would like to do sort of manipulation or mobilization. There is some point you should know before you start. The first thing, our sort of examination. You have to localize the basic movement that the patient will feel pain on. If the patient will get to the left side, where is the pain? The left side, or if he just go for the side bend to the same side. By the end of this examination, I would say this guy he has limitation during right rotation, and he has also limitation if he side bending to the same side. I know what is the limitation. I could just focus also in the area that's causing his pain. It doesn't mean that I will go to fix the flexion and extension and side bending rotation. You can't do all this stuff. The most painful movement you should focus on. Some of the acute case, the patient will come with the neck problem in the flexion, extension, side bending, rotation, all of it. But which one was the most terrible for the patient. I will focus on that movement. Also, sometimes some of the patients, they will feel discomfort, really discomfort. What they will say, you know, if I just rotate my neck to the right side and take it to extension, I will feel pain. And also maybe I will feel discomfort. Sometimes we need what we call it combined movement. It's not pure normal physiological movement. Normal physiological movement, flexion, extension, rotation to the left, rotation to the right, side bending this way or that way. But if we do combined movement, it means that we are doing two movements at the same time. I mean, you could do rotation to the left side or to the right side and do extension, or rotation and side bending. When we need this movement, if you don't find any problem with the flexion, extension, side bending, rotation, you could go with the combined movement. But if you find a pain during the normal physiological movement, you shouldn't go for the combined movement. Okay, but remember that before we start for objective examination and the treatment technique, what do you think, guys, is the most important? Is it the subjective history or the objective history for the patient? What is the most important to do, the subjective or objective? And usually in the clinic, mostly you are just take more time with the subjective or with the objective. Why subjective? The thing that I will think about is for the safety of the patient and the safety of the therapist. This is the most important thing to consider. Not all the patients who come into our clinic is for us. Maybe you got a referral from ex-doctor, he doesn't know that much. Like one of the cases that come to my clinic, and the patient, he come to us and he feel lumbar disc, like they thought for him lumbar disc prolapse. And the patient, he not able even to sit on the bed. He doesn't find a comfortable position for himself. Then gently I start to mobilize him just to see the flexion extension and the bed to see, because when he's loading his spine and standing, he can't move anywhere and he has a continuous pain. Then I couldn't do anything for him. Then I referred him to the doctor for instance, it was a mistake. The coming Saturday you should go to that ex-doctor to see what's going on. In the weekend, he admitted to the hospital and they found prostate cancer. My point is that it's not all the patients who's coming to our clinic, it's just for us. And sometimes you find some precautions. Maybe the patient has a eye problem, and you didn't ask in the history, and you start to mobilize or manipulate, and you just hurt the patient. So it's very important for us guys to know the subjective history. And in the manual therapy, we go in detail. Usually I spend maybe 30 minutes for the subjective history and less than 10 minutes for the objective. Because sometimes I know what's going on with the patient even without objective examination. Usually I use the objective examination to confirm or negate the problem. From his history, okay, this guy maybe he has shoulder injury, maybe he has dislocation with effort. But in the examination, I will go mostly with some tests that confirm or negate the diagnosis. And remember, musculoskeletal, there is no clear-cut one examination will be perfect for a patient. It means that most of the tests that you are usually do in the clinic is not accurate. It's not accurate that you can just pay attention to it and you say 100% this guy, he feels pain in extension, he has stenosis. Not all the time. Statistically, when they do the research, they don't found all these tests. It's just rubbish. It won't do anything with us. So here I will just give you a brief subjective history, how you should take it in manual therapy, what is the importance of that. Okay, first we'll go for the body chart. Usually, if you've got the patient, for sure you will ask about his name, his occupation. What do you think? Why are we asking about his occupation? Why we ask the patient for what is your occupation? Okay, maybe he developed this problem because of his work. Okay, then I will ask the second thing about his sport. If he's doing a sport or not. Not all the patients who come to the clinic, they seek, a treatment because of the pain. Maybe they come to relieve the pain. Or for the competitive people, or especially for players, they're coming to us because they want to return to the same level of the competition. They don't want to just sit as a substitution. They want to return to the same level of their, experience. So the first thing we'll just ask, we finish this one, we call it social history, then I will go for the body chart. And the body chart here usually is a useful and quick way for recording information about the area and type of the symptoms the patient is experiencing. That means that if the patient has cervical pain, I will mark the area. If he has radiated pain, I will mark this area first, then he has radiated pain down here. And then I will call this area P1, pain number 1. And the referring area, I will call it P number 2. This one will give me if this guy has two pain which is related or not related to each other. Maybe the guy has a pain in this side, but he told me also I've got a pain in my elbow. Then we'll come to another point because the relationship. And it's easy for the other therapist. Maybe you are absent that day, and the next therapist will come to you, to the patient, and already just you want to ask the patient the same question. He will find where is the problem. Okay. Before we go for the next part, just we'll talk a little bit about pain. What sort of pain that we are seeing in the patient? They've got three types of pain: peripheral, neurological pain, central pain, or nociceptive pain. And just will give you some clue about all these pains before we go further. We've got the first one is the nociceptive pain, and usually the feature of that one is just localized pain. It means that the patient will come to you and he told me, my pain in this area, localized. He won't say, I feel the pain down there, all the way around, or all the way down my arm. He will say, I've got the pain in this area only. If I rotate to this side, I will feel the pain here. This is what we call the pain. And it's easy to respond to stretch, or to compression, or movement. It means that this guy will just, I will ask him, you feel the pain here? Rotate to this side. Oops, there's a pain here. Go back, I've got the pain here. Okay, it's easy to find it. And respond to simple painkiller and anti-inflammatory. If you take some medication, you feel better, and improve with appropriate basic treatment. It means this guy, if got the pain in this side, if I start to mobilize him for 3 repetitions, then ask him, return back to the same side, oh, I feel now it's better. This is what we call receptive pain or mechanical pain, and usually it's easy for you guys to treat. It can take maybe 2 sessions, 3 sessions, and you will go home. Okay, then we've got the peripheral neurological pain. It's a follow anatomical distribution. It means this guy will feel pain in this area, which is C5, maybe here it's C6, C7, or T1. This is what we call neurological pain. Follow the dermatome distribution. And the pain that will he tell me in the clinic, he will say, I feel shooting pain, I feel sharp pain, I feel electrical pain. And usually this pain will take more time to treat than the previous one. The previous one I expect to session, if you do good mobilization or manipulation, will get better. Sometimes you need just 1 session. But I think the peripheral one, or the peripheral neurological means it will take time, because you should first treat this area and you will work with the nerves later on. And there will be paresthesia, pins and needles, any abnormal sensation, or just numbness, maybe the patient will feel in their hands. Also provoked by nerve stretch or compression or palpation. If you come to the cubital fossa, maybe here, you will press, maybe the patient will feel pain. If you just press on the ulnar nerve, this area, he will feel pain. If you press in the carpal tunnel, here, maybe he will feel pain. This is what we call it, it's the response to the nerve palpation or to stretch. If you do upper limb tension one test like that, to try to stretch the nerve, you will start to feel the pain the same thing. Okay, then the central pain, and the central pain is the worst case scenario that we can deal with. الأصعب شيء ممكن يحدث هذا بيجي كمان مع الناس اللي تكون عندهم كرونيسيتي، يعني المريض له 2 3 4 متعالج يتحمل الالم لحد لحظه يجي. هذا هيتحول الى سنترال بين، معناته هذا بريفرال انجري والبريفرال هنا sending all the time signal to the dorsal nerve. This one will get activated, and when it's activated, it will reflect huge pain more than usual. And معناته هذا ممكن simple touch you will feel huge pain. And it's not following the dermatome distribution. Most of the patients they will come to, I feel pain all around. Where is exactly? I don't know. just all sometimes here, sometimes here, sometimes there. And this one we call it mind of its own. The pain does not, he doesn't know how to describe it. He doesn't know how to describe his pain. Sometimes you will see in the front, sometimes in the back. And this is one of the pains that it's very difficult to deal with. And the drug sometimes, even though it's not effective. Okay, we know now the pain that we are dealing with. Is it resistant pain, is it peripheral pain, or is it central pain? Then we'll come to the body chart. If we return to the body chart here, usually I will choose this area to write the rest of the things that I will talk about. Here maybe I will write P. P means paresthesia. P, paresthesia, not the P here is the pain. Right here, P, paresthesia. Simply I will ask the patient, do you feel numbness? Do you feel tingling sensation? Do you feel things are needed? If he say yes, just I will write it down or mark it in the body chart. If he say no, just I will write 5. He doesn't feel anything. Then the next point will come after that, what we call it, is the constancy of the patient. Do you feel intermittent pain or do you feel constant pain? If you told me I feel intermittent pain, sometimes I feel this pain if I rotate, if I don't rotate, if I'm okay, there is nothing. If I walk, maybe I feel the pain. If I rest, there is no pain. I would think about what sort of pain that I'm dealing with. Is it nociceptive or is it neurological pain? What do you think, guys? It's a nociceptive pain because it's localized. If you do some work, you will feel pain. If it doesn't, you won't feel anything. And when we say constant pain, it means that 24 hours the patient will feel the same pain. And remember, one of the points that you should think about is when you say that a continuous pain, then you should think about it. Could be this guy, he has two things. Maybe he has inflammatory process, which is feeling the pain all the time, or maybe he has also, what we call it, maybe malignancy. The patient will feel pain here, and the pain goes down. Maybe this guy is not for me. That's why we're taking the history. The patient feels constant pain, and further in the history, he said, probably also my weight just get reduced, I feel loss of appetite. All this stuff just come with the point of this guy has tumor or malignancy. Then I will see the patient before I start my objective examination. Okay, then I will take the severity of pain. The severity of pain is very important. Why? Because I would like to know if my patient gets improved or not. I will ask him first. We've got a scale from 0 till 10. 0 means no pain, 5 is moderate pain, 10 is severe pain, as somebody take your teeth without anesthesia. Then the patient will come to me and say, oh, it's not that much, maybe I feel 5 out of 10. Then I will do my treatment. And if the guy he has a rotation inside, he has pain and start to mobilize, and they told me I've got a 5, now I will ask him, do the same movement that causes your pain, what do you feel? Now it's at 3, I guess. Then you know if the patient get improved or not. Then I will go for the nature. I will ask the patient, just describe your pain, what you are feeling. This will fit with the paresthesia. If you feel just localized pain, if you feel these needles, I would know what sort of pain that I'm dealing with. Then I will go for the relationship. Relationship, it means that I've got two pain. The patient they told me I've got pain in my neck, but also I've got pain in this area. I would know, is it two problem or is it one problem? Then I will ask him the question. If you've got a neck pain, immediately you will feel your hand is just hurting you. He said yes. This one will start first. After that I will feel a pain down here. Then I know. I won't care about this pain because if I fix this one will get diminished. But if the guy he told me, no, sometimes I feel this one without this pain. Maybe this guy has tension with it. But he come to you and he told me I've got pain. In our society nobody will just, they will come, some of the patients they will come, I've got pain on my hand. And they don't know how to describe their pain. Okay, then I will go for the breathing history. The breathing history is very effective way to know. I mean, it's sometimes it's just, somebody will say it's a waste of time to take it, but I would like to emphasize some point. The breathing history is very crucial thing to know because you should ask about irritability. Irritability means that the patient comes to you and he has a pain, and I would like to know, out of 10, how much? He said 5. Is it irritable or not irritable? He said, I've got 8 out of 10. Do you think it's irritable? هل هو مزعج؟ لما يكون 8 من 10؟ ايش الفرق لما يكون 8 من 10 او 2 من 10؟ 2 من 10 معناته ممكن he live with it, it's like nothing. But 8 is very huge. Then, do you think I will take more time in the examination with this guy, or just I will focus a little bit? Do you need to do all the examination? Maybe the patient will get worse with you. His pain will aggravate. Then next time he won't come to you. That's why you should ask about irritability. It means that I will ask the patient, if you got this pain, how many minutes it will take to settle down? لو جاك هذا الألم كم تحتاج من الوقت عشان هذا الألم يجي؟ قال ممكن 5 دقائق رجعت يدي ما فيها. كذا رجعت كذا رجعتها ما فيها. هذا اعتبر انه مزمنة ريتم. لو كان قال لي لو حركت يدي زي كذا ممكن اجلس 5 دقائق 10 دقائق على ما يخف الألم. You think المعروف في الجود الاكزامينيشن هشتغل له ابدكشن فليكشن هسوي له بنجن هسوي له كل هذا الاكزامينيشن the patient will be tired. So that's why we are taking the breathing test. It's very crucial, guys. Also, how long the symptoms has been present. هقول للمريض كم هذه المشكله هذه كمها معك؟ لها اسبوع لها اسبوعين لها 3. لو قال لي لها شهر لها شهرين هعرف طيب من شهرين الى اليوم كيف الالم؟ هنخف؟ هنزاد؟ لو قال لي لا بدل الالم يخف ممكن تكون انفلاماتوري بروسس جالسه تخف. لكن لو قال لي ممكن نفس الالم نفس المستوى ممكن مالجنسي. ماشي يا شباب؟ Is it a sudden or just slow starting? Maybe is it injury? And usually if I've got acute case, I'm happy with it more than chronic case. Chronic case usually it will take time with you because the patient will develop biomechanical posture fault with the time. Somebody is sitting at the computer for days and they develop forward posture head. And this guy he needs most time to work in the muscles, to work in the joint to normalize his posture. Okay. Then I will go for the aggravating and easing factor. Aggravating and easing factor is very important. Why? Because maybe we guide you for the problem with the patient. Just I will imagine that the patient he told me that what sort of thing that will make you worse, make your neck worse. He told me that if I just type in the computer I'll feel more pain. Do you think this is a facet joint or do you think this is a disc? What do you think, guys? Is it a disc or a facet joint? Why facet? If you do this movement, all this facet joint will open, flexion. There won't be any pain because this joint is just a bit relaxed. But if you go for extension, it will close all joints to each other. Then really it causes pain. Now, from this point, I would say this guy doesn't have a problem with the facet joint. But if I do flexion, maybe I'll push the disc to the posterior causing me pain. Maybe from this question, I would know. This is not a facet joint. Now I clear this is not a facet. Maybe I will go with this. Then I will continue. What else? Movement that may cause you, make it worse. They told me if I just continue typing. They told me during ironing, during cooking, during dressing. All these things will just put out some of this dysfunction. Okay, شباب؟ مفهوم؟ يعني حتى في الأذر كيس مثلا واحد عنده شولدر بروبلم. قال لي مثلا اي حاجه بمسكها على فوق من فوق هذه الموفمنت تسبب لي الم كبير. غير مثلا اخذ شيء من الجنب. لو اخذ شيء تحت 90 درجه ما عندي مشكله كده اقدر احرك. لكن لو اخذ يدي فوق اكثر ممكن تسبب لي الم اكثر. هل تعتقد هذا الشخص مثلا عنده مثلا شولدر ديسلوكيشن؟ ولا ممكن يكون عنده بنجامين سندروم؟ ممكن يكون بنجامين سندروم. يعني هل احتاج مثلا في الاكزامينيشن اني اختبر كل الاشياء؟ بعض المرضى يقول لي مثلا عندي مشكله في الشولدر يقول لو باخذ حاجه من ورا كده باخذ شيء من ورا باخذ شيء من اللي هو باك بوكيت احس الم. هذا كانك تختبر هوكنز سكيني تيست. يعني احيانا ما تحتاج انك تكون فيردر في الاكزامينيشن اذا انت عرفت او اخذت هيستوري كويس من البيشنت حتريح نفسك من كثر الاكزامينيشن. كمان لو كان البيشنت ريتابل ما حتقدر تسوي كل هذا الموفمنت. ما حتقدر تختبره في كل دايركشن ويدون نيد. Then we'll go for the easing factor نفس الشيء بس المريض ايش الاشياء ممكن اللي تريحه. The patient he said if I extend this way the pain will just subside. معناته ممكن هذا يكون ديسك لانه لو سوى extension it will push the disc inside. لكن لو قال لي if I do this extension cause me more pain ممكن stenosis ممكن spondylosis ممكن spondylolisthesis ممكن تكون spondylitis كل هذه الاشياء ترى تتوقعها، وبالتالي from the examination 60%, 70% I don't know what is the problem with the patient. Then I will go with the 24-hour history. 24-hour history, it means that the last 25 to 24 hours history. Why we are taking that? Because some of my patients, they will come to me and they will start to examine him. And they told me, I've got this problem, I've got that problem, and my neck is hurting me, I feel numbness, I feel radiation. And they come to you, but alhamdulillah, this day I'm very happy, there is no pain. Just will ask yourself, why? They told me that I will go before I come to you. If the patient is safe, he قال لك انه ما اخذ the medication ولا شيء, he will start happy, the patient he doesn't feel pain, or start mobilize. بعد ساعتين ثلاثة أربعة بعد ما يصير مفعول التريتمنت الميديكيشن راح, يعني أعتقد إنه حيتعالج واحد. فبليز guys, 24-hour history is very important. And remember that also some of the patients in the morning they will get more pain than the afternoon. If the guy he has degenerative changes in his neck, the first, 1 hour or 2 hours after wake up from the sleep, he will feel pain. As much as he starts to mobilize, to move, he will feel less pain. Then I would think maybe this guy he has spondylosis. Is not disc, is not whatever. Then I will ask about the evening. The evening, it means that from the morning when you wake up till now, what do you feel? I feel less pain. I feel worse pain. Then you should consider that in your examination. Then I will take the past history, as you know, normal past history. Then I will go for the social. Then I will go for the special question. I will tell you something, and I used to say it for my student in the university and for any course. I failed the first exam in my master's degree because I haven't asked this single question. I did the examination very fine, I did the objective very fine, the patient he left happy, but by the end I failed the examination because I haven't about the special question. Why? Because this is the safe question for you and for the patient. What sort of a special question that usually we ask? General health. How is your general health? The patient has diabetic, the patient has hypertension. Some of the patients, they told me I've got a disease. Do you think I will go for manipulation? No, this is not my patient. You can seek for other treatment. Then I will get the weight loss. But to start this problem, do you feel that you've lost some weight? Will just come as a coincidence with this problem? He said, yes. And they told me from the beginning, I've got constant pain, and I've got weight loss. And I say, sorry, this is not for me. I will send it to another practitioner before I start to do something. Because what you are doing is just waste of time. Then I will go for the rheumatoid arthritis. While I'm doing for ask the patient, do you have any rheumatoid arthritis and used to be your family? Because mobilization, aggressive mobilization, I mean by grade 3, grade 4, and manipulation is contraindication to those people. Because maybe you're looking for more swelling, more readiness, all this stuff for the patient. Then I will ask about drug therapy, because some of the patients, they use steroid medication, they will use cortisone, and all this one will weaken the bone. And if you do mobilization or manipulation, maybe it will break down the vertebra. Then I will ask about MRI and X-ray, and remember that. Somebody will say, why I haven't asked the patient for MRI and he told me I've got this. No need to ask all this question. But do you think all of MRI have the same clinical correlation? No. If I take 20 patients or 20 persons from outside and take them for MRI, maybe some of them, they will get a disc in their back, but it's not symptomatic. I have a disc, minor disc bulge, but it's not causing me pain. It doesn't mean that all the patients, they have MRI and they have a cervical disc or lumbar disc, they should be in pain. It's not all of them. Okay, then we'll go for the symptom of the cord sign. If the patient has bilateral numbness, bilateral pain, bilateral weakness, this is not for me. I will send him for the neurology doctor. Also, I will go with the symptom of this codequine, usually it will be for the lumbar spine. Then I will go for the vertebral artery insufficiency. This is the most important. I will ask the patient, if you've got any problem, do you feel any dizziness? Do you feel any altered vision, such as diplopia? The patient will feel like diplopia, nausea, anxiety, altered facial sensation. He has numbness in his face, in his tongue. All these things, it's a contraindication with the manipulation therapy.
TBI sometimes it will be occurred with this movement. For example, if there is some lady or someone who may take a shower and make a hyper extension for his head, maybe it will be good. So that's how to make clear roll out for this.
I'm telling you, the roll out will become with the clinical examination. But here we are saying subjectively the patient he will do. I know what you are saying is okay, but remember that upper cervical instability, if you've got a problem with the other ligament or the transverse ligament, it will give you the same thing.
So that TBI sometimes occurs without any signs or symptoms, directly, suddenly. It will come suddenly. Maybe I make hyper extension for my head, maybe I get TBI.
But I'm telling you, the most thing that makes TBI worse is the rotation, more than extension. Extension will cause pain, but if it's come with the rotation, it will be loose.
So that we know that TB artery will be supplied the back of the head.
Yep.
So that with the extension could be decreased.
Compromised.
Yeah, it will be decrease the circulation for the back of the head.
I mean, okay, I'm with you, but what I'm saying, if you ask about these things, maybe you will say, it's not confirmation all the time. We're not saying all these components should be there. But if you find one of them and you have suspicion, maybe we'll just go for physical.
Maybe maybe come to me a patient with any other problems. Maybe I make for him a dilatation extension, hyperextension. Maybe I take TBI.
I'm telling you something. If you have suspicion about TBI, the first thing you will test the TBI, you still that you have the same thing. At least when you do mobilization, you can start by grade 1, 2, 3, and it's not to the end range.
Yeah.
I could do it, but I won't put myself in trouble. I will send him for clarification. If he said, it's okay, nothing wrong with him, he can go, I will go even though after that by grade 1, 2, 3. I won't go for grade 4 or grade 5. Yeah. I don't need to go grade 4 or 5 manipulation. I will do by grade 1, grade 2, grade 3 is enough for me. Okay. Okay, if you do all this stuff, the subjective history, then you will know what is the precaution, what is the contraindication, is it this patient for you, and you will know the progression. The system pain won't take me a long time. 2 sessions, 3 sessions, you'll be fine. Neurological pain, maybe it will take me 1 week, 2 weeks. And the progression of the treatment will be not as much as you are treating the receptive pain. Okay, guys. Here we finished. I call it, all the time. It's just, the lazy introduction for any course. And I know it's not, maybe most of this knowledge you know it, guys, but at least we should put emphasize, but because we expect somebody has too much knowledge, somebody has low, and somebody just to fit all of us with each other. Now we'll start our objective examination, and usually we'll start by inspection. And you know what? I want to go deep in this stuff. Then I will go for normal physiological movement. And usually call it active physiological intervertebral movements. Okay, guys? Call it active physiological intervertebral movements. And usually we'll start by upper cervical spine and lower cervical spine. Just I need a model. Then we can show you all this stuff, then we can practice it. Okay, guys? And we just do switch on the light. And then I will start to do. I need a model, guys. One of you guys come here, just so we can show you how it is done. يلا واحد متبرع كده نشيط يلا. الهم خلاص ما عاد في ثيوري ولا عاد شيء كله عمل يلا.